Hello everyone, I'm NikolasPontikos, the inventor and chief investigator of AWARD02488, an AI tool that aims to accelerate the diagnosis of inherited retinal diseases. I've been developing this technology at the UCL Institute of Ophthalmology and Moorfields Eye Hospital where I work. Here with me today are my two colleagues, Dr. Mark Fisher, our UCL Technology Transfer Officer, and Prof. Susan Downs, the principal investigator for the Oxford University Hospital site. So here's the agenda for today. First, I'll be talking to you about the challenges of inherited retinal diseases and the genetic diagnosis pathway. Then I'll be talking to you about what we've achieved so far and what we're planning to do during the award and after the award. So what are inherited retinal diseases and why is it important to accelerate the genetic diagnosis pathway? Let me explain this to you through the story of Mohsin, age 3. Mohsin has trouble recognizing faces and has an unusual habit of staring directly into bright lights. His parents take him to the optician where a 3D scan of his retina is taken. The optician thinks it looks normal, so glasses are prescribed and no further steps are taken. However, after a year his vision continues to deteriorate and so he is referred to a specialist eye hospital. An inherited retinal disease is suspected and a genetic test is ordered. 4 years later, the hospital finally contacts the parents to say they have a genetic diagnosis and a gene therapy treatment is available on the NHS. Unfortunately, by now it's too late. The genetic diagnosis pathway has taken more than 7 years and the therapeutic window has been missed. Mohsin is 10 years old, he has no viable retinal cells left and sadly has gone irreversibly blind. Unfortunately, Mohsin's case is not unique. Inherited retinal diseases are a leading cause of blindness in children in the UK, where they affect over 30,000 individuals, surpassing even diabetic retinopathy. We estimate more than 1/3 of these individuals remain undiagnosed because of limited access to diagnostic services and bottlenecks in the diagnosis pathway. As this is a lifelong condition, this represents a significant health economic cost in quality adjusted life years amounting to more than £523 million. The current genetic diagnosis pathway takes well over 5 years on average, meaning many patients may not be diagnosed on time. The benefits of a timely genetic diagnosis are huge for patients. A genetic diagnosis gives patients some sense of control over their lives. It allows them to understand their condition, seek the right support, and to make important life choices based on this information, such as family planning. A genetic diagnosis also puts patients on the right care pathway, cutting NHS costs. There are over 20 potentially life-threatening underlying conditions that could be detected by the genetic diagnosis of an inherited retinal disease. Finally, over 1,000 individuals in the UK could be treated or recruited to a clinical trial if they had a genetic diagnosis. For these reasons, it is crucial we significantly accelerate the genetic diagnosis pathway. Our goal is therefore to accelerate diagnosis through our novel AI tool, AWARD02488. AWARD02488 will, from a retinal scan, assist the genetic diagnosis of an inherited retinal disease by producing an easy-to-understand report for healthcare professionals. Using AWARD02488 will help increase access to specialist care and address bottlenecks in the genetic diagnosis pathway, specifically by allowing opticians to rapidly detect referable cases and eye hospitals and diagnostic labs to rapidly identify the genetic cause of disease. We anticipate we could reduce the time to diagnosis from 7 years to less than a year, whilst reducing the psychological, financial, and operational burden for both patients and healthcare providers. In the case of Mohsin, this would mean that using a system like AWARD02488, we could have gotten the treatment to him by age 5, saving his eyesight. So where are we now in the development of AWARD02488? First, I would like to say we're in a unique position to develop AWARD02488 at Moorfields because we have access to the largest and most expertly curated dataset of retinal scans for these patients in the world. These diseases have been studied there for over 30 years. Our team of clinical collaborators are also international leaders in this domain, and we are embedded in national and international consortia for inherited retinal diseases. Using our in-house Morphus dataset of more than 52,000 scans that we have curated over the last 2 years, we have trained and tested a novel prototype classification algorithm to classify up to 36 gene classes. Our prototype is also the first able to use 3 types of imaging modalities in order to predict the likely causative gene. A prototype achieves a top 5 accuracy of 88% and is so far the most advanced yet in terms of clinical utility. So what are we planning to do next? We are seeking £1.3 million of funding for 3 years in order to develop i2Gene into software as a medical device. As described in our proposal, our project plan involves a number of work packages. Through the first 3 work packages, we will develop i2Gene into an explainable algorithm. For this, we will externally validate our i2Gene prototype across datasets from other UK hospitals, as well as an ethnically distinct patient cohort from Japan, and extend i2Gene to provide segmentation level information, which means annotating relevant parts of the retinal scans to offer an explainable diagnosis to end users. This will lead to making i2Gene both robust to bias and explainable. Patient public involvement has been and will continue to be instrumental to the design and development of i2Gene. Our patient advisory group is led by William Wolf, who is a computer scientist affected by an inherited retinal disease and a full-time co-applicant on this project. We are also working closely with national and international charity partners such as Retina UK and Foundation Fighting Blindness to involve as many patients as possible in our research. Our patient involvement activities will include interviews and focus groups, design of surveys, data monitoring, and of course helping in dissemination. Our health economic work package will evaluate the cost effectiveness and the value of i2Gene. This work package will be led by Professor Loggerly. Our initial evaluation will be to compare the standard diagnostic pathway to that of i2Gene. For that, a cost effectiveness analysis will be used to model resources used in current pathway versus i2Gene, and we'll be comparing the IRD diagnosed and quality gained in both pathways. In parallel, we will also conduct a discrete choice experiment survey to help us quantify the benefits and trade-offs from a patient's perspective. The usability and clinical utility of i2Gene will be evaluated as part of our human factors work package. Our co-applicant Dr. Shah will be our clinical safety officer and will lead this work stream. We will be engaging with end users in order to investigate how i2Gene fits and will be used in a clinical context, to gather user requirements, and to perform usability testing to ensure clinical utility. Regulatory approvals will be completed as part of our medical device accreditation work package. Throughout our study, we will be gathering clinical safety and efficacy data that will be documented in our technical file. We will develop our software in partnership with a software company overseen by regulatory consultants to meet compliance. Our aim is to be in a position to obtain UKCA CE marking by the end of the 3rd year of funding. In terms of our commercialization strategy, once we have regulatory approvals, we will work with UCL partners, the Royal College of Ophthalmologists and NHS Genomic Services to agree on a pricing strategy. We have identified 4 immediate market access points, which are specialist eye hospitals in the UK and internationally, genomic diagnostic testing and research services, imaging device manufacturers, and pharmaceutical companies. On completion of the award, we will seek further funding for Phase 3 to assess i2Gene on real-world data outside of a specialist environment. This will include eye hospitals that do not have a specialized inherited retinal disease clinic and community opticians. In conclusion, our mission is that in the next 6 years we will deploy i2Gene to a sufficient number of sites to accelerate genetic diagnosis so that we can provide more opportunities for children like Mohsin to benefit from sight restoring treatment, improved patient care and psychological support, and reduced financial and operational costs for the NHS.